the more we can minimize the opportunity for error, that helps my stress levels and everybody around me and helps my patients. But the idea of internal regulation or introspection is so interesting, because that is, where we can start when we're working to improve our own performance. And yeah, I like that, jiu-jitsu and martial arts and yoga and, these things are tools for self-calibration.
Hi folks, I'm Dan Dworkis, and this is the Emergency Mind podcast, a space where we bring together lessons from the emergency department and beyond about performance when it matters the most and applying knowledge under pressure. Our guest this episode is Dr. Cheryl Martin. Dr. Martin is an emergency physician and a fellow of the Australasian College of Emergency Medicine and the founder and host of the Mindful Medic podcast, which is designed to optimize performance and well-being of emergency physicians. She's a long-term yoga practitioner and a trail runner, and was recently appointed an Australasian College of Emergency Medicine Regional Wellbeing Champion. The theme of this episode is building a culture that helps us create not only excellence in our own practice, but also longevity and health over the course of our career. To get there, we go back and forth between ideas on the individual personal level and on the team and structural level that can support this. And we really explore what it would look like to build out a core collection of ideas around mindfulness and practice that every emergency provider should know. Before we jump into the episode, a reminder we are getting closer to the release of the Emergency Mind book. It's called The Emergency Mind, Wiring Your Brain for Performance Under Pressure, and it brings together mental models, tools, and lessons both from my own practice of emergency medicine and also from other arenas and experts at performance under pressure, like what you're used to hearing on this podcast. It's a book I wish I had when I was starting out as an emergency doctor, and I am honestly just really thrilled to be able to share it with you all very soon. To learn more about the book and to check out a sample chapter, head over to emergencymind.com/book. Okay, all that said, let's jump into the episode. I hope you enjoy. All right, well, Cheryl, thank you so much for coming on the podcast. I'm super excited to talk to you. I'm a huge fan of your work, and just welcome aboard.
I think the fanship is all on my part. No, I'm really very honored at the opportunity to connect with you. I have actually very recently discovered more of your work. Obviously, we both had a mutual guest on the podcast, Stephen Hearns, and it then allowed me to dive into some of the great work you're doing. And I'm thinking, when you reached out to do a crossover, I thought this is a perfect opportunity. And as I said, I'm more at risk of wanting to dive into your emergency mind, because I know the book is coming out in a couple of weeks. But I will try and hold back so that.
No, it's all good. We'll mix and match over the course of all of this. I'm wondering if you don't mind if we can start. Do you want to give folks listening like a quick overview of who you are and what you do and what your space is in sort of this whole world?
Yeah, sure. So I am an emergency physician. I am a fellow of the Australasian College of Emergency Medicine. So I'm currently here in the beautiful state of Tasmania. So that is in the northeast, the island state of the country. This is my fourth Australian state. I am probably 5-6 years post-fellowship by this point. And you probably already gathered that I don't sound very Australian. So I am a Scozzie these days. I have been in Australia for 16 years, but I originally hail from Scotland and in Glasgow. So, my mutual contact now, and one of my former mentors and still a mentor today, Stephen Hearns, hails from Glasgow. I came, I think shortly after my undergraduate medical training in Glasgow. Always been a bit obsessed with Australia. I have family here. I came when I was very young, and I think I was always determined I was going to do at least some work here. I only planned to come for a year. So I came, I think I'd already decided quite early I wanted to do emergency medicine. I did my internship, some ED in Scotland, came out. Loved it, but did go back. Had a play with anesthetics and orthopedics, and tried a few other hats on, and then really attracted to the fellowship program here in Australia, and came back and did my advanced training in emergency here. So since then, so why am I interested particularly in I suppose your subject matter, but I mean, I think this is all of our subject matters,
Absolutely.
how we think and how we think about thinking. This is core skill set for us. And I mean, I think we talk about soft skills, but this is the hard work, I reckon. And I think, why I'm interested in this, probably because like many of us, I've struggled with it over the years, and I continue to do that. A lot of this is practice. We don't call it perfect, we call it practice, because we step up each day. And I think, I know a lot of your work is focused on how we perform and improve our performance under pressure. I mean, why is this important? It's important because we want to be the best for our patients. We want to be the best for ourselves and for each other. I mean, that is the basic premise of this. And I know particularly in emergency medicine, performance under pressure is important because we are in a high pressure environment, and we do occasionally have, I heard I hadn't actually heard the term halo before. So the high acuity, low occurrence procedures or set of circumstances that can come our way at any given moment. And I know that is partly what attracts many of us to emergency medicine, but how we actually prepare for that over time is important. And I know we'll probably dive into that and, the work of, I think people like Cliff Reed. Now, Cliff would be a great person to have on your podcast.
Yeah, definitely.
He was the first person that got me thinking about yourself, your team and environment, and him and Chris Nixon and Scott Weingart, they've done some really great work in this space, and it's just developed over the past decade. But I suppose my other interest, as I've said, is, how we actually then, I think the other big challenge facing us, and, you throw a pandemic into the mix and you see how the whole thing can quite easily implode, is how we keep stepping up day after day and maintain the longevity of our practice in the face of, chronic stressors and micro traumas and the microaggressions and all the the burden of clerical load and our places of work only get busier and more complex. And I think some of this is looking at the science, some of it's looking at the art of practice. And if you want to learn something new, read an old book and the ancient wisdom. And I think for each of us, it's finding a set of tools that help us work. So I think that was a big kind of pre-opening gamble, but yeah.
No, that's awesome, and you took so many different paths in there, which I love, and we're gonna dig through so many of them. So I think that's a wonderful tension, and to explore this idea of the halo, the high acuity, low occurrence or low frequency sort of task that we have to do, that we have to be prepared for. And I think one of my previous guests and one of the co-hosts of the podcast, Andrea Austin, said something to me, which I think about a lot, which is your patient doesn't care how common or rare the procedure is. Your patient just is suffering and needs you to do it. And, so you have to put yourself in the position where you're able to do these halo style events and you're able to do them well. And you also have to tune yourself in the same time to be able to perform day after day, like you're saying. And there's a tension in there because in some sense, those tunings, some of them are the same, but some of them are quite different. And the things that prepare you to perform immediately are maybe not the same things that help you perform over long periods of time. So I hope that's a theme we can keep going back to over the course of this conversation, because I think that's a really rich, fertile ground. And
I loved the episode with Andrea. She was fantastic. It was a really powerful clinical example she gave as well.
Absolutely. Yeah. So when did you first start thinking about that tension? Where was it in that whole arc of your training that you first said to yourself, hey, I'm learning all these skills, but geez, I have to somehow figure out how to apply that. And there's these rare things and these day things. And you balance what Andrea Austin's saying with like what Christina Shenvi said in one of the previous episodes about raising the mean of all of your shifts and sort of doing the work to take the average of your shifts across and bring that up. But when did you first start thinking about that?
Yeah, I mean, so I think I have been thinking about this. So in terms of those high acuity, low occurrence scenarios, I think the first kind of real experience I had that was in the clinical space. So after I returned from Australia, I did, and I joined an anaesthetic training program. And I was in a district general hospital, and we do our, a couple of months of kind of mandatory training before we're ticked off to be on nights on our own. So we're the airway person for the hospital, usually somebody pretty junior down in the emergency medicine department. And I remember, a couple of weeks of very civilized 9 to 5, general anesthesia, putting in some LMAs and, doing some really controlled intubations, and it was all very nice. And I was due to be starting my first 7 night shifts as the airway person, I think the following week. And they had, so this was probably, anesthetics were early adopters, and they had a high fidelity sim lab that had been set up in Stirling. And I will never forget this day. It was pretty miserable, as was quite often in winter in Scotland. And I remember driving up there in the dreary pouring rain, and I don't think I had done much pre-reading. I don't think I had at that point. I'd done a wee bit of, ABC, kind of ALS through my medical school training. I always really enjoyed it. So I wasn't too fazed. And the things that I remember, I think I was up first, was the first thing. And I was put in a room and we were being filmed. And the audience were outside. And I think I had one assistant inside. And I was given, a young man who I think he had a testicular torsion and he needed a rapid sequence induction for emergency theatre. And I thought, right, okay, I've just learned this. I can do this. And, started the process, and then quite rapidly found myself in a can't intubate, can't oxygenate situation. And I floundered. I was thrown. I still recall this as, Stephen Hearns will talk about stress inoculation. This was stress inoculation. And I don't know if it really had the psychological safety side of things in retrospect, because it still comes across as quite traumatic, but definitely was a learning opportunity. And I remember coming out and, I think they just cut the scenario at a certain point. So there wasn't even really a kind of endpoint. And then quite soon after this, we were shown Martin Bromley's very powerful, this is just a routine operation. So that was just after this. And, the brilliant work. And I think if you're not familiar with the work of Martin Bromley, so this would have been, sorry, for people listening, this would have been 2007. So not long after this came out, and Martin is a pilot with a lot of aviation experience, who were, well primed in many of these things well before we were. And very tragically, his wife died during a routine ENT operation in this very scenario that I found myself this morning. So it was really powerful stuff. But it, I still remembered it. This is many, many years on. This is 14 years on. And I have to say that probably those night shifts I went on to do in Glasgow in the middle of winter and in DGH were probably more of a baptism of fire. So it probably wasn't necessarily, all bad. But yeah, the ability for us to do better. This is why we need to do better.
So I want to build some structure around what you just said to translate some of that for folks that are coming at this from a different angle. Even as I wish you could have seen my heart rate as you're describing that story, because I know that feeling you're describing. So when you go to place a breathing tube, when you go to anesthetize a patient or do a rapid sequence intubation, you can occasionally and quite rarely end up in this circumstance where you can't intubate and you can't oxygenate, meaning that you can't place a breathing tube, and more importantly, you can't get oxygen into the patient's lungs. This is a very rare circumstance, and the answer to this circumstance usually is surgical front of the neck access, meaning that you're at that point abandoning what you're doing and cutting the patient's neck open to put a breathing tube directly into their trachea. It's a really rare circumstance. Most of us go extended periods of time without having to do that procedure, without having to end up in that circumstance. And some people go most, or if not all of their career, never actually ending up in that circumstance in real life. And if you look at the data surrounding when emergency doctors or other operators of one sort or another really run into trouble in that circumstance, one of the things that you pretty consistently see is that the switch in your mind to realize I am now in a can't intubate, can't oxygenate scenario. And the mental work that it takes to abandon the previous mental model that things were going okay and operate now from this other reality and to rapidly accept that reality and move, it's actually that step. It's the recognition step that appears to be the hardest for most of us, not actually physically accomplishing the surgical front of neck access in most cases. And so that type of a problem, which is how and when do you realize that there's been a sea change underneath you and you now have to react to an entirely different reality, is a really deep and powerful and very challenging problem that everybody who operates in emergency situations needs to become familiar with and face. And whether or not you're performing emergency anesthetics and intubating people, like maybe you don't have to decide if somebody's in a can't intubate, can't oxygenate scenario, but if you're operating in emergencies, you need that skill set of dropping your previous universe and realizing the universe that you're actually in. And man, that is hard. That is so hard. And that feeling that you get when you're sort of realizing, oh, geez, this is about to happen is, I mean, there's no way to describe that over a podcast. It's just this visceral sort of like pull that you get into. And um, so I feel for you in that scenario. I think that's an incredibly hard thing. I'm so happy that they put you through that in training before you did your night shifts. What an awesome thing to feel that and to be sort of thrust into that fire before you get into it in real life. Now, have you ever found yourself in a can't intubate, can't oxygenate scenario in real life after that?
Fortunately, not thus far, but as we know, that could happen any day. And I think that building on that, the work then that we started to talk about Cliff Reed, I started to attend some of his courses. He had a course on making things happen. I mean, I think anybody listening in the space who's interested in his work, I think things like his, advice to a young resuscitationist or emergency medicine and making things happen. YouTube, I think it was from SMAC. Webinars are, they should be mandatory listening. So I attended a couple of his workshops to try and start to develop my own skill. And I suppose that was about the time I was trying to build up my own, my readership around this. And I'd be interested to see what kind of, learnings and what material you went to over time. I certainly, Cliff gave me a lot of kind of, I suppose, novels and other books that have guided my practice since. So we had things like the Rise of Superman, the Flow, I hadn't really mastery, Thinking Fast and Slow, all of those. And I had to say, I find this quite interesting because I had to go back further, and I'd be interested to know if even before you did medicine, if this was something that you were interested in this topic even then.
Yeah, I mean, I grew up doing martial arts, and there is a really interesting I mean, there's flashing back to a bunch of scenarios that in as a younger person, but you have all this sort of like theoretical knowledge about how stuff works, and then okay, all of a sudden somebody's trying to punch you in the face, and is what you're thinking about actually something that you can bring to bear in that moment? And that skill set of recognizing reality changing underneath you and around you, maybe even when you can't physically see what's happening or the person's behind you or something like that, is a big piece of that. And for me, I think going into starting to run resuscitations and starting to run traumas and realizing, hey, I'm using the medical knowledge that I had from school, but I'm using a lot of the procedural and functional knowledge I have actually from sort of the martial arts world. And well, what is that like, and how does that work? Um, and there's this book, Deep Survival by Lawrence Gonzalez. And I don't know if you've ever come across this, but
I think I have come across it. I do. Yeah. Whether I've read it or somebody has recommended it.
Well, he studies people who have survived disasters, and he tries to get to talk to them about how is it that you've made it through this really crazy thing like shipwrecks and avalanches and things like this. And it's an incredibly interesting book. And one of the things he keeps coming back to is this idea that there's this thing that he sort of describes as the survival mindset, which is that the way your brain and your body works and your view of reality and your view of your place in the universe has to fundamentally change for you to survive a type of event like this. And you either adapt and become this new human in a new part of the universe, or you don't, and you don't make it out of the avalanche. And I was just blown away when I read that, because to me, that is so much of what we're doing in the emergency department, right? I mean, we're not under an avalanche, but we're looking at somebody whose oxygen sat is rapidly falling off. And you're realizing, hey, this is actually a different universe than I thought it was. And therefore, I have to be a different human than I was a few minutes ago in order to make it through this next step, or this person's going to die right in front of me. And, that understanding that, well, hey, you can change your relationship with what's happening, accept what's happening, figure out a better way through it. And then, okay, well, if that's possible, then how do you set up the right circumstances and the best opportunities for you to succeed at that? How do you build your mind and your team and your environment the best way to do that? And it's just sort of a rambling arc about the way that I approach some of that. But
no, I've listened to you, and I think Cliff talks about, he does jiu-jitsu as well, and talks about the martial arts experience. And that my kind of background is, more from the kind of yoga, but it is very, very similar. I mean, you talk about, actually, when I listened to your episode on sang-froid, this idea of, stability or your performance and maintenance of equanimity under pressure. It really reminded me of, we were talking on one of my episodes with Dominic about Duriti, with one of the yamas, this idea of steadfastness in the face of ever-changing circumstances. I mean, it is that, it's the same thing, but what it kind of boils down to is, can you regulate your own internal space? And also, I think there comes a point where you can actually control what's happening right about you. I think we need to set up safe systems to allow us to do that. And I think that is part of the challenge that we face day to day, is that our systems don't necessarily support, we do work in an organized chaos, but there are certainly ways that we can offload some of that and decrease cognitive load and make it a safer place. It's laboratory of errors, Pat Crossbury said, the emergency department. So the more we can minimize the opportunity for error, that helps my stress levels and everybody around me, and helps my patients. But the idea of internal regulation or introspection is so interesting, because that is, where we can start when we're working to improve our own performance. And yeah, I like that, jiu-jitsu and martial arts and yoga and, these things are tools for self-calibration. So I'll just one anecdote, if I may. I think that so my dad, I don't have anyone medical in my family. And my dad is an accountant. And he fell into his work. It was all apprenticeship in those days. And I think he literally did turn up at the pub one day, and his friend was in a suit, and he said, "Come along, I'm going for an interview." And they both got offered a job in an accountancy firm in Glasgow. And they ended up partners of that firm many years later. Fortunately, my dad actually loves accountancy, but he did go to university in his second year. But I think he found himself quite early on. It would be the late 80s, early 90s, the kind of rise of, Peter Drucker, the knowledge worker, and he was a workaholic. I'd never see him. He wouldn't be home for dinner. He'd work on the weekends. It'd be books, and I don't always remember just books everywhere. And I suspect he was probably quite a stressful boss to be around at that point. He had an ulcer, and there's a few things. And I always remember I was about 11 or 12, and I came home one day, and my mom was like, "Shh, your dad's sleeping." This was on a weekday, and I was like, "Oh, Dad's never in." And he was sick. He'd got some kind of gastro bug. I always remember looking round into the room, and he was green, ashen, just looked really ill. And the next thing I remember is the next morning sitting at breakfast saying, "Oh, how's Dad?" He's gone. He got up at 4 a.m. to drive down south for a business meeting. So this kind of happened. And then a few weeks and months later, my dad fell in a hole. He basically was really tired. He'd lost his enthusiasm. He went to a few doctors. They were like, it's chronic fatigue. I mean, he had a perfect storm or setup there for a post viral illness. It's like, it wasn't rocket science really. And he did a wee bit of so searching through that time. He didn't really drink, didn't really smoke. I think he found a GP a bit interested in kind of lifestyle and integrative approaches to health. But I think the main thing that he did was start to focus on his own stress management and self-regulation. And so this was in the day before our podcasting would have been available, and he had tapes, these cassettes. So I would go to school as a teenager. He would drive me there, and we'd be listening to Peter Drucker, Stephen Covey. I was gifted the Effective Executive or my first year at uni. That was my first week. My brother got it too. Whether I actually read it at that point, I'm not sure. Some Deepak Chopra in there. It was a bit of everything. But even to this day, and my dad's never stepped on a yoga mat or he's never done martial arts, but he is one of the most kind of equanimous, kind of very, very easily, not very easily flustered men that I know. And I think that's all the work that he has done. So I find it quite interesting that, I think that's the work we're still doing today.
Yeah, definitely. And what is that? You used a great word before that story, which I love. Introspection. What does introspection look like for you? Like in your day-to-day life? Like are you still reading? Are you still listening to those Stephen Covey tapes and Deepak Chopra, or like what does introspection look like for you?
For me, I do practice yoga every day, and my mat is rolled out next to my bed. And, I think some days that will be 5 minutes of form, breath, intention, meditation, which we might talk about at the end. But, check your form, where am I holding tension? I'm a tooth grinder. I know a lot of emergency medicine physicians that grind their teeth. After a set of night shifts, I famously grind out half a molar, actually.
I'm laughing because I recently went to the dentist when it was again safe to do so, because it wasn't for a while at the beginning of the pandemic, and the dentist who's a wonderful person, looks at me and goes, your teeth, you look like you've been grinding your teeth. Have you been under any stress lately? And I sort of blinked at him with my mouth open and all the instruments in and said, I'm an ER doctor practicing in a pandemic. Like, yeah, there's been a little bit. Yeah. But okay. So you do a bunch of yoga and you do it every day, and you've been doing it for a long time.
Yeah, so 20 years. I've taken some time out post fellowship and done some more dedicated training. I've worked with athletes. I've worked with there's a group of us around the world who do a wee bit of work with patients. Yeah, there's some really interesting, kind of trying to marry the art and science. But essentially, there's a lot of misconceptions about what yoga is, but it's essentially a self-calibration tool. It's just a tool. And the physical postures might be a way in to my podcast is Mindful, and people think I can't spell, but the reality is that paying attention on purpose in the present moment is really hard, and you need a way in. And the reality is most of us are busy and in our head. So for me, my practice, and it is a practice like everything else, like you in jiu-jitsu, it's the real yoga happens off the mat and in life, like the real martial arts, and I am under no illusions that throwing yoga a group of emergency practitioners is going to, help all of the challenges that we face. I mean, I think many of these, I know we haven't gone on to the kind of longer side, but I really feel that our performance and our health and well-being are closely interrelated. And many of the challenges we face are at much bigger levels than ourselves. And we've now got some good data to support that. And, there is a lot of work happening, but I think, integrating and percolating this through training. I certainly I do a lot of running as well. And I find the Sports Gene, there's another great book by David Epstein. That was one of the early books that I started to look at, mastery. And there's a big body of, science and art of practice from some certainly sporting literature. And, I think about all the things that I have done. I've had a coach in my athletic career, and, I periodize my training. I drill this deliberate practice and the idea of, I love that book, Peak Performance, which is a bit like, there's so many variants. So like Anders Ericsson's book, Peak, is great as well. But the idea of, incubate, so immerse yourself, then incubate, then insight, to actually improve our performance, the idea of adaptation. But I think also married with that, the opportunity to recover and to actually get the benefits of your training. And I think the problem we have is that there's so much work to be done. And when you're certainly training, there's so many hours and so many night shifts and so many weekends, and we have to do the work. But we don't necessarily do any kind of deliberate practice. I certainly did not periodize my advanced training well. I didn't prioritize my basic needs. And I think I'm very strong for our from the trainees that come after me now to I have the Fellowship 101 talk where we talk about all of these things that I probably in retrospect could have done a lot better.
Yeah. And so what would that look like for you if I gave you a magic wand and told you that you could redesign emergency medicine training? How do you think that would come together? And maybe this is a good opportunity also to sort of go back to that tension we were describing between needing to be ready to do these incredibly intense moments, whether they're a halo exercise or not, versus being able to have a long growing career over the course of your life.
Yeah. And I think this is a great question. And I don't think there are any easy answers, but there's certainly a lot of things that we can start. There's plenty of places we can start. And I agree that probably as a trainee, those peak performing procedures that I needed to be ready for, I think that you certainly will ameliorate your stress if you're prepared for those things. And, we've got some great programs now. We've got the procedures course here in Australia where we look at those very procedures. But I think if you're, a DMT or you any consultant, because you get the opportunity to teach on the go at any point with your trainees, to be able to actually hone those through the program. So we can definitely do that side. I think the things my biggest challenge is the day-to-day cognitive overload and the kind of, we call it, I think it was Cliff again, who talked about the zigzag walk. You go to see patient A, you do your history examination, you form your plan, you turn to go across the room to execute said plan. And then you get asked en route to write up some pain relief for patient B. So, before I write up strong pain relief, I like to see the patient. And then you've done that. And then, patient C, can you just have a wee look at this ECG? Then again, you need some clinical context. And then there's a call overhead. We've got one of the gastroenterologists on about patient D, about a referral you made earlier. So you go to do that. And then you kind of get to where you were going and you were thinking, what was I actually here to do? And I think, there is a lot of danger in that. And, I know Steve talks about frazzle, but I think that is more how we set up our departments in terms of how they're organized and what support systems we have to decrease the cognitive burden. Certainly, if we're talking specifically about trainees, I think smart rostering. You've just described to me that you're doing some night shifts and then some teaching and then going on to day shifts. And, that I think the science would probably say that, obviously doing shift work in actually rotating it in terms of your circadian rhythm. So going from days to evenings to nights, there's certainly a bit of work around that would be helpful. I think appropriate rostering for time off for trainees. I know that I think also periodization through their training program, and that's something that you can start from day dot. I ran together 12 months of emergency medicine in a trauma center with then 6 months in a tertiary pediatric center in winter to then ICU where it was a week on, a week off, nights and days. And I was doing my research project on the week off. I think that was to be 50 hours. And, that wasn't smart. I was exhausted at the end of that. And if I'm really honest, I love my job, but I ended up I limped towards the end of my fellowship and I felt a bit spat out the other side. And it took me a wee bit of time to actually, I'd lost a bit of I thought, I thought this was going to be the pinnacle of my professional career. Really the learning continues, but I think I could have done it much better.
Yeah, that's such a good way to put that, feeling spat out the other side of it. I think that's unfortunately all too common of a feeling about it. And you're getting so many like really good things in there about how we could be designing things better. And I guess and maybe this is something we started talking about slightly before we hit record, but that there's I sort of think about it in like these like pillars or these clusters, right? So there's like the internal work that you do as a human. There's like
Mm,
the work that you do as part of a team, and the work that you do as part of a group and a structure. And then
mhm,
maybe a fourth bucket would be sort of like human factors, ergonomics, the way that all these things sort of fit together. And that if we're trying to design this from scratch, we really need to design intelligent pieces for each of those things and then allow us to actually train on them based on what we know about how training works. So
mhm.
I guess my question is, what would a different universe look like where we train but we don't feel spat out the other side?
I mean, all of the things that you just said, the supportive systems, the appropriate rostering, the time and space to recover, recharge, restore. I suppose I mean, it's culture first. It's making a whole culture that's geared towards us winning and doing our best and performing our best. And I think that's multifaceted. I mean, I think James Clear is so eloquent on this. We rise to the level of our goals, but we fall to the level of our systems. I really love that, because I think if you're going to have any evidence that any of this works, you need buy-in at all levels. And if you can, I think it's a key performance indicator, because at the end of the day, it affects patient care, but you want, people involved and invested. And, I think, I don't know if you've read any of that article. Have you read the 9 organizational strategies? It was a paper produced by
No, I
Tate
haven't.
Shanafelt, Noseworthy, a couple of years ago. So they've been measuring this stuff for 15 years. So really performance, engagement, and they're using burnout criteria and leadership scoring systems. I think it's all anonymous at individual level, but aggregated at system unit level. And there's really interesting data, and some basic things that come out. So certainly, we set the tone. Leadership is always right up there as being important, but also in terms of our longevity of practice, the idea of developing niche. If you can do like 1 day a week, and you obviously have a number of interests, and I know that this is probably our little passion project in terms of something that we do outside of all of that. But, if you can spend a proportion of your time, 20% ideally, that kind of sweet spot, which might vary depending on who you are, doing the thing, that part of your work that most engages you and enthuses you, that's really important. But I think the thing I found disappointing in some of the study work was that a lot of us couldn't identify what that is. Have we got to the stage where we can actually recall or identify the bit of our work that is most important to us? So all of those, little things. And I think in terms of, very basic things at department level, just engagement. A few studies we talked about, we talk about on my podcast, the Compass trial. I think it was colleagues meeting to promote and sustain satisfaction, where they basically just got everybody to give them a bit of money to go outside and have a meal outside the workspace once a month. And they then measured engagement, enthusiasm, kind of a few other criteria afterwards. And lo and behold, actually people thought this was actually pretty good, because they were removed from the clinical space. They saw their, referring physicians as humans. That helps us all. They recreated this in New Zealand, the EDGE study, ED get exercising. So, yeah. So, do
So
you do anything like that in your own clinical environment?
So we do. I mean, I think everywhere that I've worked has some version of wellness and mindfulness training and resilience training and burnout training, and I see the face that you're making, and I have to say that I agree in a lot of ways. And it's no knock on the training that we have, but I don't think that it answers the fundamental questions that we're talking about, because this tension that we're describing, where you need to train to do the acute event and you need to train to have a long, healthy, successful, universe as an ER doctor or whatever you are, like like figuring out a way to actually support you in that is a challenge. And individual trainings on burnout is well intended, but doesn't really speak to me on a lot of that question. I'm not sure it makes it happen. I'm not sure it really pushes the needle. You said
I mean, I
something.
agree.
Yeah.
And I think the reality is when you're training, and we've spoken about this, I spoke about this with Christine, when you're peaking to do anything, a bit like in sport performance, it's work, and you have to embrace the suck, and there isn't balance. That isn't a reality, certainly when you're coming up to do something, like become an emergency physician and get to the peak, what you think is the peak of your performance. You realize that there's another curve, after that. But, prioritizing your basic needs, still should be essential, because I think you become unstuck. And I think and I think that is, you have to set the system up to at least be able to do that.
Right. And so there's this low-hanging fruit that seems to be small changes that you can make that creates more of what you described as a few seconds ago as, like a culture that sets us up to be able to win. Right. And that's what's so fascinating to me, is that there's such space in there that you don't have to reinvent the entirety of training. You can make these small nudges in order to sort of make things slightly better. And for me, part of that is actually just to build the vocabulary and the framework to talk about this kind of work, right? To talk about the fact that, hey, how I feel in my life, how I prepare will actually affect my on the job work, as well as my off the job sort of life and time. And there's um, there's this idea I keep coming back to that I wonder what you think about, that we really should be training emergency staff like we train athletes.
Yeah. Well,
Right.
yes.
I mean, that
Yes.
seems so obvious to say that out loud like that, except that that's so
I've
different
said
than what
it
we
so many
actually do.
times.
Yeah. It's so different than what we actually do. And for you and for anybody that's listening to this, I'd love to hear your take on this. What are small things that we can do that nudge the culture away from what it is now and nudge it towards the culture that sets us up to succeed and win? And I'm going to use the word flourish from Martin Seligman's sort of positive psychology aspect. But what are the things that we can do that are small, that nudge our emergency practitioner culture towards something that lets us flourish as individuals and teams?
So you want me to answer that? I mean, so many things. I'm just thinking of, I think, like, just how I know that how I turn up each day matters. And I think that when I'm leading a team, and I have to be conscious that I do set the tone. And when it's really busy and I start throwing my toys out the pram, I'm not helping anybody. It's actually one of my colleagues yesterday. She at the start of her handover, she'll do a brief 2-minute timeout meditation, and she says, you're welcome to just think about your shopping list if you want, but for those who want to join me in this, we're going to do this, and we're going to set our intention for the day. And I'm gonna, I know you've given me a little homework to for the end of this podcast, and we might play with that. But when I jump on a yoga mat, I do that. I set a sankalpa or an intention. I think that should be something that I'm then taking off into my work. I think that having time out, I think communication always throughout the day, and making sure people take breaks. So my job on a day-to-day, when it gets busy, I think it's more important that people take breaks or take time out, because they're no use to me I'm no use to myself if I don't take a break, and I have to be the example. And I think that if I can I've been quite organically doing the Compass trial for a number of years now. I have a group of female colleagues and I don't know why we don't have any male colleagues in that. They would be welcome, but it's just ended up that way. And we, every quarter, we're all now in different states, and obviously through COVID, we haven't actually been able to meet physically, but we'll still make our dinner and do the Zoom, just get together. I think having critical friends as well as mentors and coaches are important. You're obviously setting up formal mentoring. and maybe coaching. We can talk about coaching. I think maybe I'll talk to you about that after I've read The Emergency Mind. I've got a coach coming on, our next doctor's coach coming on next week, so that will be hopefully I'll have picked her brains by that point. I think, like you say, having access to good, healthy food. I think even having, visual aids. We talk about cognitive aids for high performance things, but visual aids for, for your own health and well-being, and maybe when you're going to bed tonight, dim the lights, maybe go for a bath, remove the do a memory dump, write down all the things from your day, or remove your devices and switch them off an hour before. I think we there's now science to manipulate your pineal gland. We should be doing this.
Strikes me again that what you're describing is really all across the spectrum that we set out earlier. So there's like individual things that you do, like you set an intention when you show up, and you like have a certain, I'm going to use the word ritual when you're going to sleep that you're sort of working and experimenting on. And that's like internal, like I have to find that for myself. I have to experiment with different things and see what actually fits. And then there's the team, which is I'm going to make sure everybody on the team takes breaks, and I'm going to normalize taking a break. And I'm going to normally say that, hey, look, our performance gets better when each individual team member is healthy and rested. And then there's organizational stuff, which is creating the culture around this being how we don't do this because we are weak and can't handle it. We do this because we're stronger when we do this together. And our patients need us to be as strong as possible. And setting that out as the culture of the space to say, hey, we're going to lead by example, and we're going to do these things because we believe they make us better. And also saying, well, maybe we don't know. We have to experiment together as a team about it.
And what do you think? I think that, and I will admit that I struggle with this. I still fail every day, and I think I've got to fail up and declare that. But I think the other thing is, if you just mentioned, and I screw up my face, resilience and mindfulness, and all of the kind of buzzwords for people that maybe are very resistant to that. Because I think that I even now, because I think these things are so overplayed and so overdone that the actual kind of purpose is lost somewhere. How do you get buy-in there? How do you reckon you get everybody? And maybe it is, as you say, setting up the whole system that
I think about this one article I read when I was really early in medical school, and it was actually about social determinants of health. And it was by this guy Gruen, and he had this series of ovals in the article, and the ovals were labeled essentially in terms of like how we should be training people. And the analogy that he used was about heart disease. So everybody that studies medicine needs to know some things about heart disease. People that are really interested in heart disease should know slightly more. And then people that are absolute experts, that are interventional cardiologists, then they can choose to pursue expert training in this particular thing. And that sort of nested oval model is, I think, my personal answer to this, which is that there's, no matter if you hate or love mindfulness, or if you're, whatever you are, there's some things that every one of us who perform under pressure need to understand. We need to understand the relationship between our internal environment and the external environment, between letting go of where we don't have control, between accepting reality, and the way that what we do before we show up makes a difference in what we're able to do when we show up. We all have to know that. And so I think there's some sets of trainings that have to be for there. Then there's the opportunity, the space for people to become champions in this that really love it, and to go on and do special training. And so maybe you have, in the same way you have somebody in your shop who is the expert at ultrasound, maybe you have somebody in your shop who's expert at individual introspection and team performance, and the human factors person in your shop. And that's a role that somebody plays. Are
you that person in your shop?
I'm certainly trying to become that person. Yeah.
Good.
It's
great.
I love that. And I wake up thinking about this kind of stuff, and it's an absolute joy of mine that when our residents step up and take over the code bag, which is when they're the ones who respond to a code blue scenario somewhere else in the hospital, we do a pretty intensive training right around that period as they're going through that liminal space of becoming the person who runs that event. And I think if you made me list out the things I'm most proud of, then being the person who delivers the mental factors and human factors talk for that training is one of the things I'm hands down the most proud of, because I think that's a space where I can really make a difference for
Yeah.
individuals.
And you undoubtedly are. No, and yeah, I think you're right. And I think we are seeing this, across the board. I think there's I think there's enough of us interested. Yeah, and it is another facet of how we show up and how we get better.
So then it becomes, okay, well, if we believe there's this nested oval model of what you have to know and what you could know, and then, I think the way you described it is what you must know, what you should know, and what you could know, or something like that, right? There's these levels between it. I think it falls on us to try to start to define, well, what's in there that we absolutely really need, that every person who trains in emergencies and who performs at the front line, what do we must know? What must we know in order to actually do that work? And then, like, what's really amazing and wonderful, but like only if you want to.
Yeah. So what would you put in the, everybody, non-negotiable skills?
All right. That's the worst part of asking a question like that, is then you have to turn around and try to answer it. But
I think it's really interesting.
Yeah. So, a couple of things to me that jump out as being incredibly important and non-negotiable is the idea of, it's actually sort of a Stoic philosophy concept, right? So Marcus Aurelius says, realize that you have control over your mind and not outside, or rather, you have control over your mind and not outside events. Recognize this and you will find your strength. And I think the idea of understanding where you have agency to act and where you don't, and that there's a boundary in there that you have to explore, really is non-negotiable, because that sets you up as a foundational kernel for this idea of, well, I control how I show up for work. I don't control what happens when I'm at work, but I control how I show up, and I control how I train and how I study and how I prepare and how I drink water and how I choose to do these things. And recognizing where you do have that control is part of stepping up as a professional to actually exert that control. And a similar version of that, I think, is the idea that it's up to you to experiment to figure out how you personally perform under pressure. That's sort of a ground truth that nobody's, I can tell you, hey, the dose of amiodarone in the middle of a code in a, VTAC is 300 milligrams. I can't tell you exactly what you're supposed to do to be able to remember that and deliver that knowledge in the heat of the moment when everything is chaos all around you. That's actually up to you to sort of figure out through experimentation.
Yeah.
And I don't know, I think there's a lot of that. And I certainly don't believe that I understand the whole space, but I'm hoping that through conversations with you and with everybody else that comes on this podcast, we can try to start to define some of that space about, well, what is it that helps people, that people really need in order to perform under pressure.
Yeah, and I think this is what we're starting to see, and there's certainly people in, most of our departments, taking a portfolio to champion some of this, and as you say, I do think, there are the two sides, and there is an overlap, because everybody that's trying to, the Chris Nixons and the Cliff Reeds and the great things about the full med space, where we, the coda change and our ability to hone our actual skill set, but then marrying that with the longevity and the other things, because they're all interconnected. And I think there are tools, and it's having tools. I think in the meantime, people listening to this and stepping up in their own space and doing small things each day matters, and continuing to replenish my book list, which is great.
There's this James Clear, to quote him again, quote that I really love. He goes, "Intensity makes a good story. Consistency makes progress." And I think that's, to me, maybe the crux of a lot of what we've been talking about today, about this idea that like you're going to have these intense moments that you're going to prepare for and you're going to train for, and that's going to be a good story. But then what? What do you do the next day? How do you drill that? How do you be consistent in your quest to sort of be a better version of you in that next day? What you said, to keep showing up for work every day and to try to be better as you go.
And I think, I mean, a lot of these things, like any kind of improvement or performance, is because you're not getting immediate feedback. Your actual, incremental improvements accrue over time, and suddenly. But it's like any new practice, new habit formation. That result will eventually manifest, and then you'll be on to the next one. But I think also that when we were just going back to what we're talking about, interoception and just the basics of knowing when we're, the halt, so hungry, angry, late, tired. And I think I was listening to a great talk by Catherine Henderson, who's the president of the UK College, and she said, when sad and overwhelmed, what do you do when, first of all, can you identify that you are in any of these situations and that you are struggling? And then second, about do you have a plan then? Do you have a critical friend? Do you have someone that you can reach out to who's senior for support? And I think having a culture where people are able to actually reach out if they're struggling is important too. I mean, I really like the idea of driti and some of the Stoic philosophy, but I think the ability to actually show emotion is important as well. I know we have to be able to regulate and control that in the heat of battle, if you like, but I think being able to have an outlet is important too. We're human.
Absolutely.
It's the humanity side of medicine.
No, we are not robots. We are people, right? And I think that we have to act like that and believe that. And that's certainly something I'm learning as I continue to get older, both as a human and as a doctor. But I think that one of the things I love about the Stoics is that it's not really about not feeling things. It's not about not having emotion. It's about feeling it and then understanding what that teaches you about your place in the universe, and then working about thinking to yourself, what type of human do you want to be, and what's the link between where you are and where you want to be. And it's that sense of self-experimentation and self sort of sharpening. I'm not sure if that's the right word or not, but to continue to practice being yourself as you keep going.
And I think I find it interesting that throughout my medical training, despite, what we're doing day to day, and we're dealing with people at the best and worst times of their life, that, I think we do become quite good at internalizing certainly, I mean, my own experience is that being able to kind of override my own kind of emotions. And when I went back to study yoga in a bit more detail and look at some of the the ancient texts and start to kind of process some of that was when I was starting to think, it was ironically that I was thinking then more about myself and as you say, your place in the universe and all of the other things that I think will really, my training, I thought I would have been more in tune with this, but actually I wasn't. And yeah, again, maybe it says more about me than it does my training, but I do think that we, there comes a point where we do have to bury a few of the things to be able to show up again every day. So I think that if you don't do that judiciously with due outlet, it will come back at a later stage. And yeah, so. But as I say, a work in progress. I think that I think it's a very interesting area for me now and exciting, because I think, well, where can we go with this? And as you say, how can we work smarter and better moving forward? Because our job is great and it's so important. And I want to keep showing up for this job for for a longer time. I don't want to not be able to do this. I know some amazing emergency physicians practicing in their 70s and probably should be asking them, well, what is you're still here and you're still showing up every day. Maybe you've been doing all of this all along, or maybe it's something else.
All right. Well, Cheryl, let's bring this home as we close out the episode here. What challenge do you have for people that are listening? What do you want them to do differently tomorrow? What do you want them to try and practice?
Okay, so I've actually borrowed this, and I don't know the original source, and it's something that I'm working with this week. It's something introduced to me not that long ago, and I think it came from palliative care teaching, but it is actually, I think, originally an emergency medicine based challenge. So I want you, it's called the going home checklist. So we'll use a checklist. I want you to take a minute to think about your day at the end of your shift this week. And firstly, just acknowledge one thing that was difficult and then let it go. And then I want you to consider three things, because we know the power of positive things and the ability to negate things. We need more positives. Three things that went well. You might think why they went well, but just what went well. Check in on your colleagues. Are they okay? Are you okay? And if you're not okay, who are your critical friends? Who are your seniors? Where can you go for support? And I want you to switch off. Your tension now is to going home, to resting, recharging, reconnecting with your family, with your friends, and scheduling in some joy if you can. So that's what I'm going to be working with this week. And yeah, I invite everybody listening. And, no matter where you're working, I think that's a good going home checklist.
That's awesome. I love that. Thank you for that, and thank you so much for coming on the podcast. I'm super excited to do round 2 in the other way around and do that.
Thank you very much for connecting. Keep up the great work. I'm really looking forward to reading the book, and yeah, looking forward to round 2 because I get to really dive into the emergency mind then. Thanks very much, Dan.
Okay, folks, that brings us to the end of this conversation. I hope you enjoyed it. I hope you found something useful that you can use next time you find yourself in an emergency or a crisis. Again, if you want to dig deeper into a lot of the concepts that we covered here, sign up for the Emergency Mind newsletter, Knowledge Under Pressure. It is free and it is awesome. You can join by going to www.emergencymind.com/signup. Also, as a reminder, our mission here at the Emergency Mind is to dig into lessons around applying knowledge under pressure, not to provide medical advice. Our opinions, as expressed on this podcast or elsewhere, are our own and not necessarily those of our employers or the hospitals at which we work. So keep up the good work, keep training, and good luck out there.